Hey, Farm Buddies, it's Lisa, and we are going to start talking about Chapter 34 today. Chapter 34 talks about drug therapy for fluid volume excess. So basically, we're talking about diuretics. The lecture is going to start out with a little bit of discussion of some terms we need to know. We're going to talk about some kidney A and P. You guys don't know me really well yet, but I'm obsessed with kidneys. And anytime I can sneak in some talk about the kidneys, I'm going to sneak in some talk about the kidneys. So we're going to talk about some kidney A and P. That's just going to help you understand a little bit about how the medications are going to cause more urine output to get rid of that extra fluid. Next, we're going to, talk about our drugs a little bit. When you guys are listening to my lectures, I like to talk about nursing interventions, and I like to talk about patient teaching. So pay special attention to what you need to think about as a nurse and what you need to teach your patients. That includes diets. One of the big things we talk about in this lecture are different diets. Potassium sparing diuretics need a specific diet. Potassium wasting diuretics need a specific diet. Some of them have effects on sodium, so we need to be aware of those when you're listening. One other thing you guys will notice, I'm not sure if your previous lecture has been recorded this way, but I have mine set to continue flowing so you can listen to the slides, back to back to back. You don't have to hit play every time. So if you want to take notes, you have to hit stop and take some notes. I do recommend, though, that, listen once, take notes, and then I'm sorry, you have to listen to me again, listen to it again, and actually listen to the lecture and listen to what I'm saying instead of stopping to take notes the entire time. That's probably my best study tip for pharm, is if you can listen to it once, take notes, listen to the lecture the second time, and try to really understand what we're talking about. So all of that being said, let's get started on chapter 34. Let's start by reviewing a couple key terms that we might talk about when we're talking about fluid volume overload. First term we might talk about is anasarca. So anasarca means generalized massive edema. So your entire body is just completely swollen. So anasarca is very severe all over the body. Next thing we might talk about is anuria. So anuria means no urine output. So when I talk about diuretics being a poor choice for people that are anuric, think about if you're not making any urine, the whole point of a diuretic is so you pee out this extra fluid. So if you're not making any urine, diuretic's not going to work for you. So if you're anuric, diuretics are a bad choice. Next term we've got is ascites. So ascites is going to be fluid volume overload or fluid buildup in the abdomen. Sometimes you see those old guys that have like big beer bellies. So some of that extra fluid in the abdomen can be referred to as ascites. So it might not be in their lower extremities or upper extremities. It's going to be kind of concentrated in the abdomen, ascites. Next one we're going to talk about is edema. So edema is just that general medical term for swelling. We can talk about dependent edema. So dependent edema is going to be dependent on the lowest point in the body. So if I was sitting in a chair, I might see feet and ankles. If someone's arms dangling down low, you might see their hands start getting swollen. Sometimes in the hospital, we even see it in the groin, in the scrotal region, because if you've got the head of the bed up and the foot of the bed up, down there, the lowest point's going to be right there in your fold area. So sometimes you'll see scrotal and groin edema because of the dependent position. Generally, edema is just going to be an excess buildup of fluid in that body tissue. So this kind of brings us to the next thing we're going to talk about, extracellular versus intracellular. I found this really nice picture. I think it helped kind of clear everything up for you guys. So intracellular is going to be fluid that's inside the cells, so it's circulating around. Extracellular is going to be outside of the cells. generally we're going to see some communication between those two things. Like you can see in the picture, the water and the electrolytes kind of flowing back and forth through there. But that extracellular fluid, that's where if you see a buildup, you're going to see, the edema start to show up because it's not circulating through the cells like it should. So that's going to be that buildup in extracellular fluid. Next thing we're going to do is review some of our renal patho. So our renal system is made up of the kidneys, the ureters, the bladder, and the urethra. Main thing we're going to be talking about are our kidneys when we're talking about these diuretics. So to review a little bit about the kidneys are responsible for lots of really important things. This is why they're my favorite organ, right? So your kidneys help to regulate volume. They decide how much urine or how little urine to make. They also decide the composition of the urine. So how many electrolytes we're going to get rid of, how many electrolytes we're going to keep, that kind of thing. Kidneys help to regulate your body's pH, and they do that by keeping or excreting those hydrogen ions that can affect the pH. They also are going to filter and eliminate waste, so things from medications, stuff we eat in our diet, muscle metabolism, all that stuff can be cleared by the medications. Next, we've got our BP regulation, so regulating our blood pressure. You guys remember learning about the RAS system and cardiac. So you remember the RAS is going to increase blood and oxygen flow to the kidneys. Those kidneys are like high maintenance girlfriends, right? When they're not getting that blood and the oxygen, they're kind of whiny. Oh, where's my blood and oxygen? Brr, brr, brr. So then they're going to start activating that RAS system. So it can, kind of cause that vasoconstriction, get more blood and more oxygen flowing to the kidneys. Also part of that RAS system, remember, is stimulating erythropoietin. So erythropoietin, remember, is responsible for stimulating the production of new red blood cells. So the new red blood cells are also going to increase volume, right? More oxygen, more blood to the kidneys makes them happy. Last cool thing that your kidneys are going to do is help to maintain strong bones. They do that by activating vitamin D into its active form in the body. So since the kidneys do so much awesome stuff, they're going to get a ton of blood flow. 25% of our cardiac output. So each heartbeat, 25% of that blood flow is going to our kidneys. Tell me they're not important organs. Come on, guys, right? So that 25% of cardiac output is going to enter the kidneys through the afferent arteriole, right off the aorta. So think aorta, afferent arteriole, all those A's, right? So blood's entering the kidney that way. The blood is going to filter through. We're going to talk about that in the next slide. And then it's going to return to the body through the efferent arteriole. I remember that E for efferent, E for exit. So it's going to exit the kidney to go back to the body through the efferent arteriole. Because all of that blood needs to be protected from injury with the body, the kidneys are going to be covered with this nice fibrous tissue layer called the renal capsule. Kind of makes it a little safe area for all that blood to be. Underneath the renal capsule, you're going to have 3 layers of kidneys, and they each have a little bit different functions. So the outer layer is going to be the renal cortex. Inside the renal cortex, you're going to see part of your nephron. And the middle layer is going to be the medulla. The medulla is going to contain our loop of Henle and the collecting ducts. So the loop of Henle and the collecting ducts are going to be important when we talk about our diuretics. And the most inner part of the kidney is the renal pelvis. So the renal pelvis is going to take that newly made urine that's made from the cortex and the medulla, and it's going to get it ready to go down to the ureters and to the bladder. So I mentioned the nephron being in the renal cortex, and the nephron is going to be the functional unit of the kidney. So the nephron is kind of like a chunk of the important part of the kidney. We're going to talk about it a little bit more in each slide. Each kidney, though, it's kind of cool, has about 1 million nephrons. So 1 million little chunks of awesomeness in each kidney. So let's talk a little bit more about this nephron awesomeness. So nephrons, your textbooks call the functional unit of your kidney. So the best way I can really try to explain your nephron is kind of like the mall. So the name of the thing, the nephron, includes a whole bunch of little pieces and parts of things that do important things for the kidney. So when I talk about the nephron, I'm kind of talking about the mall. There's a whole bunch of little stores in the inside, but you just say like, hey, I'm going to the mall. So when I talk about the nephron, I'm talking about kind of this whole big chunk of little pieces and parts of the awesome part of the kidney. So the nephron, your functional unit, right, does all of these cool things. First thing it does is glomerular filtration. So glomerular filtration is just like it sounds, it's the filter. It is going to filter out stuff that is good and needs to stay in the body. So you might see things like, sodium, potassium, um, pieces of protein that your body wants to keep. That stuff's going to stay. And then stuff that we want to get rid of. So sometimes extra electrolytes, extra glucose, maybe medications we want to get rid of. That's going to be filtered out and pushed into the urine. So the glomerulus is where that filtration happens. Then we've got tubular secretion and tubular reabsorption. You don't have to sweat this too much, just kind of understand the tubular secretion and the tubular reabsorption. That's where it's deciding whether it wants to keep that substance or if it wants to let go of it. So if it's reabsorbing it, it's reabsorbing it back into the body for your body to use. If it's secreting it, it's secreting it out to be gotten rid of with your urine. So let's talk about the glomerulus a little bit. The glomerulus, remember we talked about, is going to be the first stop in the blood that's coming in the kidney. So the blood is going to come in off the aorta. A for aorta is going to tell you A for afferent. So off that aorta, down that afferent arterial, blood is going to come in and it's going to hit the glomerulus. Because it's coming off of an artery, it's going to be under high pressure. That's me punching my hand to show you the high pressure. You can't see it. So blood's coming in under high pressure and it's going to hit that glomerulus the first thing that it sees. When it hits it at that high pressure, it's going to push the water and the electrolytes and the other solutes out. Almost like a colander if you were making pasta, right? You dump that hot pasta water in there. It's going to filter out what it doesn't want and keep the good stuff that it wants to keep. So after it goes through the glomerulus, wrapped around that glomerulus is Bowman's capsule. Kind of looks like a catcher's mitt. I have a really nice picture on the next slide. I didn't have room on this slide, but we'll look at it next time. So wrapped around that glomerulus, we've got Bowman's capsule. Bowman's capsule catches the stuff after it's been filtered through the glomerulus and then weaves it down through the tubules. Down through the tubules is where you're going to see a lot of concentration and dilution and electrolytes all getting tuned up for that urine that we're making, right? So our glomerulus, again, the big filter, we want it to filter really fast because you want to pump all that blood through. You want it to be really efficient. So it's going to pump so fast, 125 milliliters a minute, if we were going to measure how fast we want it to pump. That measurement is known as the glomerular filtration rate. So this is a lab work that we draw that can tell us about how efficient that filter is. So you want it really fast, clearing a lot of toxins, clearing those electrolytes. If it's working really well, 125 milliliters a minute, you're going to be pumping out about 2 liters of urine a day. Once that glomerulus starts getting clogged up or damaged, you're going to see lower filtration, and that's going to lead to less urine output. So after the blood has gone through all of this, it's going to leave that glomerulus through the efferent, remember E exit, efferent arterial. All right, so here's this really nice picture of the nephron. Like we said, the nephron's kind of like the mall. It has all the little pieces and parts that we need for healthy kidney functions. Kidneys have about 1 million of these nephrons in there. So there's 1 million glomeruluses, 1 million Bowman's capsules in each kidney. So breaking down the picture a little bit, you can see that blood is coming in and it's going to go to the glomerulus first, and that's where that filtration is going to happen. Then it's going to get caught by that Bowman's capsule that wraps around the glomerulus, and it gets filtered through those tubules. As far as like the details in this picture, where the sodium's going, where the water's going, you don't have to worry about that so much. Just know that through the tubules is where the concentration and dilution, kind of the refinement of the urine is going to happen. You can see down there the loop of Henle in the medulla, the collecting ducts down there in the medulla. And then, so your future urine's getting threaded all through here. All of that chemistry magic is happening, and it's going to create your final urine. So that's going to go down to that renal pelvis, where it's going to get filtered down the ureters and down to the bladder. All right, so I like to do these questions through my PowerPoints so that we can kind of break up that content and review. If you don't do good on these questions, I recommend running back and reviewing that information again before you carry forward, because it's just going to build upon it. So question number 1, where is the loop of Henle found? So the correct answer is D, nephron. Remember, the nephron is the functional unit of your kidney, kind of like the mall, kind of a generalized term for a place where there's a bunch of other little things in there. So inside of the nephron, we've got the tubules, which include the loop of Henle. We've got the glomerulus. We've got Bowman's capsule. Kind of all the nitty-gritty of what happens inside of the kidney are going to be included in the term the nephron. We reviewed our A&P. Let's take a look at some conditions, some medical conditions that might require the use of diuretics. So we're talking about alterations in renal function. Remember, we talked about that glomerular filtration rate, so how fast the glomerulus is filtering the blood. The slower that gets, the less urine that we put out. So sometimes to kind of poke the kidneys, make them work a little bit better, we can give some diuretics to help increase the urine output. Some other conditions you might see, sometimes some cardiovascular disease. So hypertension, heart failure, sometimes fluid buildup from liver failure. Those can be helped by diuretics. Burns, traumas, allergic reactions. Sometimes those lead to a lot of swelling, so we can use a diuretic to help decrease a little bit of that swelling or edema. Let's talk about what causes that edema, though. So we can talk about increased capillary permeability. So increased capillary permeability is part of the response to tissue injury or allergic reactions. So when we talk about allergic reactions or inflammatory reactions, part of it's going to be this capillary permeability, and that opens up and lets fluid flow from the blood vessels into that extravascular space, leading to that swelling, right? So if you get, you have an allergic reaction, right? Your face swells up. That's part of that inflammatory response from the capillary permeability. You can also have swelling from increased hydrostatic pressure. This one's a little bit more confusing. So this is from an increased blood volume causing high venous pressure, and that pushes the fluid out of the capillary beds. You see this with fluid overload. So there's so much volume on the inside that your body kind of pushes it to the outside. So that's where you see the swelling. Again, we can use diuretics to try to decrease some of that volume, so your body will kind of suck some of that fluid back in. Third thing you might see that causes edema would be a decreased plasma oncotic pressure. So this one's a little bit confusing as well. Again, just kind of grasp the concept that the things that cause edema can be treated with these diuretics. So this decreased oncotic pressure is the result from low plasma proteins. So your plasma proteins kind of hold on to this fluid and keep it in the inside where it should be. If you have low plasma proteins, then you don't have a really strong pool, and that lets the fluid weep out into the external tissues, and that's where you get swelling from that. So again, a lot of reasons why you might need to use a diuretic. So our big clinical manifestation, our big symptom is going to be swelling. There can be a lot of different causes, but the main thing that we're talking about is going to be this swelling. So again, edema, kind of the generalized term, can be caused from a lot of different things. Like we said, allergies, burns, kidney failure, a lot of different things can lead to edema. Again, you can see alterations in fluid and electrolytes. Once your kidneys start to malfunction, everything the kidneys do start to get a little bit jacked up. So you're going to see a lot of trickle-down effect from there. Again, when we talk about edema, we've kind of got different types of edema. We talked about dependent edema, which is at the lowest point in the body. So like if your legs are down, it's that lowest point down there. Pulmonary edema is going to be some edema in your lungs, because we need your lungs to breathe. Pulmonary edema can be pretty serious. Usually you see pulmonary edema that comes along with really severe fluid overload. And then we've got anasarca. That's that term for massive generalized edema. So all of these types of edema, we can use diuretics to help treat. Hey, look at this, buddy. We made it to question number 2. Is the following statement true or false? Edema occurs only when the heart no longer functions efficiently. All right, the correct answer is false. Why is it false? Because edema is the excessive accumulation of fluid in body tissues. It's the symptom of many types of diseases. Remember, we talked about it can be from inflammation, it can be from fluid overload, it could be from burns, from low plasma proteins. All kinds of things can cause edema. So to treat this fluid overload, we can use diuretics. Again, diuretics are going to increase our urine formation and urine output. So talking about our drugs, we have 5 classes of diuretics to choose from. They're all going to work in the renal tubules except for osmotic diuretics. They're going to work a little bit differently, but we'll talk about that. So we're going to talk about all 5 types: loop diuretics, thiazide and thiazide-like diuretics, potassium-sparing diuretics, osmotic diuretics, last one, carbonic anhydrase inhibitors. I kind of like this slide. You can kind of see in the tubules where these diuretics work, just so you can kind of get an idea in your head when we're talking about these things. There are a few important things to think about when you're choosing the diuretic for your patient. So first thing you want to think about is your patient condition. Are they having an acute problem, or are we looking to manage a long-term chronic condition? Also, we want to look at what the cause of the fluid overload is. Next, we want to think about our loop diuretics. So loop diuretics are the preferred medication for an acute crisis. If we need rapid diuretic effect, like I need your patient to be peeing right now, loop diuretic is going to be the best medication. Loop diuretic is also a good choice when your patient has some renal impairment. It's not ideal to use diuretics with renal impairment, but if you have some, a loop diuretic is going to be the one that you want to choose. Next thing we want to think about are our electrolytes. Potassium-sparing diuretic can help prevent problems with low potassium. Potassium-wasting diuretics can lead to low potassium. So we really want to look at what our electrolytes as well when we're getting ready to choose these medications. So think about what's the patient's condition, think about is it an acute or a chronic problem, and then think about their electrolytes. Our first class of diuretics we're going to talk about are loop diuretics. This is the strongest diuretic, the big dog. If our patient is in an acute crisis, this is the one that we want. Our example loop diuretic is going to be furosemide, but we also have bumetidine and torsemide are loop diuretics as well. These loop diuretics can come in oral, IV, IM. We've got a couple routes we can give them. Obviously, IV is going to be the fastest and strongest acting medication. These loop diuretics work by slowing the sodium reabsorption in the loop of Henle. So remember, water is going to follow sodium. So if we stop the sodium from being reabsorbed in the body, we're stopping the water from being reabsorbed in the body. So if we're not absorbing it, then we're going to be peeing it out. So loop diuretics are going to help you pee out sodium, help you pee out water. It's going to produce significant fluid loss, like up to 20 pounds a day. Like you are peeing your face off with loop diuretics. So because they're so powerful, we use these in the worst situations: management of pulmonary edema, congestive heart failure, and hepatic and renal disease. We can give loop diuretics like furosemide alone, or we can give it with other medications to treat high blood pressure. It's good for patients with renal and hepatic impairment that's leading to fluid overload. Really good for critically ill patients because it works so strong and so quickly. And it can be used in patients at home. You can take the oral version of it, so you can help manage chronic diseases with furosemide. Some adverse effects of loop diuretics like furosemide include fluid and electrolyte balances. Obviously, anytime that we're peeing up to 20 pounds a day, we might see some electrolyte imbalances. So you might see hyponatremia, but especially hypokalemia. Loop diuretics are potassium wasting. So all of that urine that you're making, you're also going to be losing potassium in there. So really watch out for low potassium. It can be very dangerous with your patients taking a lot of furosemide. And also because of all that urination, we have to look out for fluid volume deficit or dehydration. We can get really low blood pressure because of these diuretics. And the next thing is really important as well: ototoxicity. So if we give this medication too fast, or if we let it build up to a toxic level, we can have ototoxicity. It can cause ringing in the ears. It can cause permanent hearing loss. So be really careful with that. Loop diuretics are going to be contraindicated in anuria. Remember, early on in the lecture, we talked about anuria means you don't make urine. So if I give you a medication that's supposed to make you pee a lot and you don't pee, it's not going to do anything. So contraindicated in anuria. Also contraindicated in allergies to sulfonamides. A couple drug-to-drug interactions to worry about. We've got an increased diuretic effect if it's taken with cephalosporins and aminoglycosides. And steroids and digoxin can increase the risk of low potassium, so it can be really dangerous. All right, here's the important part, guys. As nurses, what do we need to think about before we give these loop diuretics like furosemide and torsemide? We want to make sure that we are giving it slow push. Put a star by this one. I already did for you, but put one by your notes. Slow push, 20 milligrams per minute if we're giving it through the IV, so that you don't cause that ototoxicity. Next, before we give this medication, we want to make sure we're checking our labs, especially that sodium and potassium and kidney function. Because this medication is going to cause loss of potassium and loss of sodium, we want to make sure that they're not already low before we give this medication. We want to make sure that our kidneys are okay before we hit them with this medication. Then we want to make sure that we have some baseline weight information. We're keeping accurate eyes and O's on our patients. This will help tell us how much fluid they've lost. We also want to make sure we're monitoring the vitals, watching really closely for hypotension. Once they start peeing and peeing and peeing, that blood pressure can drop. If we're giving this medication orally, say you're sending your patient home on this medication, You want to advise them to take it in the morning. That way they can get all this heavy urination out first thing in the morning. They're not waking up in the middle of the night to go to the bathroom. Last thing we want to teach them is make sure that they are safe when they're getting up, because they're going to be getting up frequently. They're going to have some urgency with this medication. They could have some dizziness from low blood pressures. We want to make sure that we're safe, that they're not falling once they get up. As far as our patient teaching, here comes some diet information. You want to make sure your patient's on a low sodium, high potassium diet. Again, that counteracts that loss of potassium that we're going to get. That low sodium is going to help them to not retain as much sodium, so hopefully we won't need as much diuretic for them. Patients want to keep a daily weight so they can see if they're retaining fluid. You want to teach them to take it first thing in the morning and change position slowly so they don't get dizzy and fall at home. Our next class of drugs are going to be the thiazide and thiazide-like diuretics. So they're basically the same drug. They have the same effect. They're just chemically a little bit different. So our example drugs are going to be the thiazide, hydrochlorothiazide, and the thiazide-like is metalazone. So this is going to be an oral medication, not nearly as powerful as our loop diuretic. So this one's going to be good for kind of a home maintenance use. Hydrochlorothiazide, or HCTZ, is going to decrease the absorption of sodium and chloride. Again, it is going to decrease how much sodium and how much water is retained in the body, so it's going to make you urinate. This one's going to work in the distal convoluted tubule, not in the loop of Henle like those loop diuretics. So this one works in the distal convoluted tubule, but kind of has the same action of decreasing that reabsorption. These thiazide diuretics like hydrochlorothiazide are going to be the first line treatment for hypertension. They are also good for edema associated with heart failure or kidney disease. They can be used with some patients with renal impairment as well. They're not as hard on the kidneys as some of the other ones. Our big adverse side effects with the thiazide and thiazide-like diuretics are again going to be related to fluid and electrolyte balances. So we've got hypotension, we've got dizziness, we have hypokalemia. These drugs also have an effect on glucose, so you need to watch out for hyperglycemia, as it can be one of the adverse effects. Hydrochlorothiazide is contraindicated if patients have allergies to sulfonamides, just like with the loop diuretics. Also contraindicated with that renal failure and anuria. Again, not going to make any urine. As a nurse, when we're giving these drugs, our thiazide and thiazide-like diuretics, hydrochlorothiazide, metalazone, those are our two. As a nurse, we want to make sure we're checking our labs, again, looking at that sodium, looking at the potassium, looking at our renal function. With these meds, we want to make sure we're looking at our glucose because of that hyperglycemia adverse effect. Then you want to make sure we're getting that weight, keeping track of it daily, make sure we're keeping strict I's and O's, watching our vitals for hypotension. Again, give it first thing in the morning so they can get the peeing out early. You want to monitor their safety as well. Patient teaching, going to be very similar, that low sodium diet, so it stops all that extra fluid retention. For this one, you want a high potassium diet, again, because it's going to be potassium wasting diuretic. You want to make sure you teach your patient to record their weight every day, make sure they're changing position slowly, and make sure they're taking their med in the morning. So we talked a little bit about potassium. I want to talk a little bit more about potassium. So our loop diuretic and our thiazide-like diuretics are known as potassium wasting diuretics because you're going to urinate out potassium. So hypokalemia can be very dangerous. It can cause some serious cardiac arrhythmias and even death. So we definitely want to avoid that, right? So in an effort to avoid hypokalemia, we're going to do a couple things. We're going to try to use the lowest dose of diuretic possible. We are going to try to use supplemental potassium. So generally, if you're looking through your patient's meds when you're in clinical, if you see them taking furosemide or you see them taking hydrochlorothiazide, you may see them taking a potassium supplement, a K-DIR or Slow-K. So you'll see that potassium replacement to try to counteract the effects of the potassium wasting diuretics. You may see a combination of a potassium sparing and a potassium wasting diuretic to try to kind of even it out, so they can use low doses of both to try to kind of keep it an even potassium level. You want to make sure that we're teaching our patients to increase their intake of potassium. So, take your medication with a banana. That's going to help increase your potassium. And you always want to teach them to restrict their sodium intake. If you're eating a lot of McDonald's, you're going to retain a lot of fluid, which is going to mean you need a higher dose of diuretic. And then we're starting all over in the beginning. So we want to make sure that we are monitoring our potassium. Remember, normal potassium is 3.5 to 5. So we want to keep it above 3.5. Signs and symptoms of hypokalemia can include confusion, weakness, heart palpitations, GI upset. Like I said, if it gets too low, it can be fatal. Oh, bam, we made it to question 3. What assessment findings in a patient with heart failure receiving furosemide would indicate an improvement in fluid volume status? Correct answer is A, absence of crackles on auscultation. So crackles are going to tell us that there is extra fluid in the alveoli. So if I don't hear any crackles, that means that excess fluid is gone, means my lungs are working better. Our next class of drugs are the potassium-sparing diuretics. Our example potassium-sparing diuretic is spironolactone. You can almost see sparing, maybe it's a stretch, right? But you can almost see sparing in spironolactone to help you remember that. This medication is probably the weakest diuretic action. It is slow to start. It takes about 48 hours to start getting that diuretic effect, and it can actually take up to 6 weeks for its maximum effect. So this medication is not good at all if our patient is actively having an issue. If they're, actively short of breath, swelling all over the place, this is not the med for them. If we're trying to work on, long-term treatment, this is a good drug for them. So the spironolactone is going to block the effect of aldosterone. Remember, aldosterone is part of the RAS system, the renin-angiotensin-aldosterone system. So this is going to block the aldosterone. Again, a weak diuretic effect. You're not going to notice a ton of urine output with this one. Usually we're using this medication in combination with other diuretics because it just doesn't work that awesome. This medication is a good choice for long-term treatment of heart failure, for ascites and liver disease. We can use it to treat mild hypertension. And then this one's kind of interesting. You can use it to treat hyperaldosteronism. So if you happen to have hyperaldosterone, so you have high aldosterone, this is a good medication because it blocks that aldosterone. So we can use it for that as well. Some adverse effects you might see with these potassium-sparing diuretics, like spironolactone, include some androgen-like effects. So you might see things like gynecomastia or breast growth in males. That's gynecomastia. You might see irregular periods in females because aldosterone works like an androgen, which is the male sex hormone. There's also a black box warning for an increased risk of tumors if you build this up into a toxic level. So be careful with that. This drug is going to be contraindicated in renal insufficiency and also with high potassium. Again, if we're sparing potassium, it's going to keep potassium in our blood, which is going to make our potassium high. So if our potassium is already high, This could be very dangerous. Also, same thing with renal insufficiency. If your kidneys aren't clearing potassium very well, giving them this potassium sparing diuretic puts you at a really high risk for high potassium. So this can be really dangerous. And then we've also got some drug-to-drug interactions with our ACE and ARBs and potassium-containing drugs. This is just going to put you at a really high risk of having high potassium levels, or hyperkalemia. It can lead to deadly levels. So we avoid our ACEs, our ARBs, and potassium supplements while our patients are taking these potassium-sparing diuretics. As a nurse, when we're giving our potassium-sparing diuretics like spironolactone, big shocker here, we're checking our potassium level, we're checking our kidney function. We're going to get that baseline weight and a daily weight. We're going to keep strict I's and O's, and we want to monitor our patient for safety. As far as patient teaching, really important here, this medication is going to require a low salt, high potassium diet. Again, that low salt because it's going to cut down on fluid retention. You also want to avoid salt substitutes because those salt substitutes have a chemical in there that tastes like salt, but it's really high in potassium. So you're secretly eating a lot of potassium even though you're trying to be healthy. So make sure that we tell them to have a low sodium diet, but avoid salt substitutes. Low potassium diet. So avoid that orange juice, avoid that banana, avoid that spinach. Teach them the daily weight. If they have liver disease, remember we talked about ascites, that big beer belly that grows. You can teach them to monitor their abdominal girth. So look for that swelling in their abdomen. Also want to teach them to change position slowly. Take this medication in the morning. All right, so we've talked about hypokalemia. Let's talk about hyperkalemia. So hyperkalemia with our potassium-sparing diuretics is a big concern. We basically can kill our patient with high or low potassium. Not to scare you to death, but just to make sure you're aware of it. So this case, we're talking about hyperkalemia. So this is a potassium greater than 5. In an effort to prevent high potassium, we are going to use that combination of potassium sparing and potassium wasting medications. Again, trying to get the maximum diuretic effect with the minimum effect on the potassium levels. You want to make sure you're teaching your patients to avoid potassium supplements in this case. Avoid salt substitutes. Again, they have that main ingredient in there that is a potassium derivative, very dangerous for our patients with potassium issues. And you want to make sure that they're maintaining their urine output. So they want to be peeing out that extra potassium that their body has. Again, hyperkalemia is a potassium greater than 5. Some signs and symptoms of high potassium that you guys should be aware of. We've got muscle cramps. We've got some serious EKG changes. You can have hypotension, heart arrhythmias, and again, death is a risk. So now that I've scared you to death about potassium, let's move on to a little bit different type of diuretic. So next we're going to talk about osmotic diuretics like mannitol. So mannitol is a little bit different, works differently than the other diuretics. It's given in a drip. It's usually in the critical care areas. And last time I worked, it's still up to date. It's given in a glass bottle, so be careful with this glass bottle. Mannitol is going to work by changing the osmotic pressure in the glomerulus, and that's going to pull some extravascular fluid into the blood. That way it can be filtered through the kidneys and urinated out. So it's going to decrease the reabsorption of water and electrolytes. Again, blocking reabsorption means I'm going to pee it out. So this medication is used to reduce intracranial pressure, or it can be used to reduce intraocular pressure. We see it a lot of times with head injuries or after like a head trauma or head bleed, helping to decrease that intracranial pressure. It is effective if patients have poor renal circulation because this one doesn't really affect how the loops work. So our adverse effects with mannitol are going to include changes that are related to that sudden fluid shift. Like I said, it's usually given in critical care because it can be a really strong medication. So this medication can cause dehydration, it can cause cardiac dysrhythmias, and then it can cause this really different adverse effect called a hyperosmolar non-ketotic coma. So you don't really have to know what that is. You'll learn about it in critical care, but just memorize that a hyperosmolar non-ketotic coma would be caused by mannitol, an osmotic diuretic. Some contraindications for this medication include if the patient is already dehydrated, you don't want to give this medication. If your patient has severe pulmonary edema or heart failure, older adults, you want to avoid giving this medication because it's pretty serious. As far as our nursing implications, you want to make sure that we are monitoring our labs really closely, that we're monitoring our vitals. We can have serious hypotension and dehydration happen pretty quickly with this medication, keeping a close eye on those INOs. Mannitol is a medication that if it infiltrates, can be really toxic to the tissue. So you want to be aware of what the antidote is if you're giving this medication and it would infiltrate. You want to know that you want to give this hyaluronidase. All right, our last and extremely weakest diuretic we're going to talk about are the carbonic anhydrase inhibitors, or CAIs. Our example drug is going to be acetazolamide. So this acetazolamide is a very mild diuretic effect. It's going to work by reducing the formation of aqueous humor in the eye. So acetazolamide is going to be used to treat open angle glaucoma or secondary glaucoma. Some of our adverse effects are going to include metabolic acidosis. And then there's some more serious side effects if we were going to give this drug IV, which I have never seen done or really even read about. Generally, it's an eye drop to treat glaucoma. So we're really only going to worry about the eye drop effect. So acetazolamide used to treat glaucoma. The big adverse effect that we would be worried about is only metabolic acidosis. All right, this medication is going to be contraindicated if our patient has non-congestive glaucoma, because that non-congestive means that it's not caused by a buildup of aqueous humor. So by getting rid of the aqueous humor, it's not going to help us out. Again, the other more severe contraindications would be if we were giving this the IV form. The only one we're really going to worry about is the eye drop. As far as our nursing implications, you want to make sure that we have a baseline vision exam so that we know if this medication is working or not. And you also want to make sure that you're teaching your patient taking a CAI, that they know how to give their eye drops properly. If you don't know how to give your eye drops properly, make sure you take a second and Google how to give your eye drops properly, because that could be a question on the exam. Ta-da! We've made it to the last but not least question in chapter 34. Question number 4. A nurse is instructing a patient on dietary considerations while taking spironolactone. Which of the following statements made by the patient indicates further teaching is necessary? High five! You guys totally nailed it. The correct answer is B. I should use a salt substitute instead of regular salt. That is the wrong thing to say. Most salt substitutes use potassium chloride because it tastes like salt. So you want to definitely avoid that if you're on a low potassium diet. Some other foods that are high in potassium that should be avoided with spironolactone include things like bananas, spinach, orange juice, all those things you don't want to take when you're taking spironolactone.